Hi, welcome everyone. Giving folks a chance to get in from the waiting room, and then we'll get started. All right. Well, thank you everyone for joining us. So for folks who don't know, I'm Kelsey Johnson. I am the program manager here with MAPNet, our technical assistance center for early psychosis teams here in Massachusetts. And today we are very happy to be welcomed by Dr. Keshavan and Dr. Shute to talk about outcomes from a kind of long-standing study comparing cognitive enhancement therapy and social skills training for folks with psychotic disorders, which they will tell you a lot about. So I will start by introducing Dr. Keshavan, and then he will also give a brief introduction for Dr. Shute. But as many of you know, Dr. Macheri Keshavan is the Stanley Cobb Professor and academic head of the Harvard Department of Psychiatry at Beth Israel Deaconess Medical Center. He has conducted early psychosis intervention and research for nearly 3 decades, and founded one of the first early psychosis clinical programs in the nation in Pittsburgh in 1990. So he's published over 600 papers, 4 books on psychotic and related disorders, including early psychosis neurobiology and intervention. And he's been developing efficacy testing and implementing cognitive enhancement therapy in the early course of schizophrenia over the past decade. And this Project Success, really is a testament to that, and very excited to hear some of the outcomes of this longstanding work. So, Kesh, if you want to take it away from there.
Yeah, thank you, Kelsey, and good morning, everyone. First of all, let me uh, introduce my co-presenter, collaborator, Dr. Russell Schutt, who is the professor of sociology from UMass and also faculty at Harvard Medical School in the Department of Psychiatry. He has done decades worth of research on different aspects of sociology of mental illness. And in the last several years, last couple of decades, has been researching schizophrenia. And I'm going to say a little bit later as to how our collaborations began. So, what we are going to talk today is a little bit of a research talk, but does have clinical implications for early course psychosis, which is why we wanted to launch our first presentation of the results of this study in a MapNet meeting. And this study uh, was designed kind of shortly before the pandemic began, before even we knew that there was going to be a pandemic. And we, in retrospect, somewhat naively called it Project Success. Uh, s- I'm known for coming up with acronyms, and so I came up with this Schizophrenia Understanding and Comparing Cognitive Enhancement and Social Skills Training, Project Success. So, we may have, yeah, been able to accomplish, at least in partial success, some of the goals of our study. And, given the pandemic, it was not exactly an easy study to do. So, with that as the background, let me say a little bit about why this study was conceived. We all know that schizophrenia is probably one of the most highly disabling of all medical illnesses. And of course, the most highly disabling illness in psychiatry. And there are two pathways to impaired functional ability in this illness or impaired community functioning. One is what we have learned over the last few decades, that the core dysfunction in this illness is neurocognitive impairment. The other core dysfunction that we know is that there are deficits in social skills in this illness. So these two key measures conspire to lead to this high degree of disability in this illness. Um, Dr. Schut, who is a sociologist, has always reminded us that we are all social animals, and humans, Homo sapiens, functions as a social being, and anything that we understand in regard to major psychiatric illnesses such as schizophrenia, we need to understand the social underpinnings and also the social neuroscientific underpinnings. And so, how Russ and myself and the late Professor Larry Seidman, we used to have long conversations about how schizophrenia might be such a highly disabling illness, and we need to understand the social brain in order to understand this illness better. We wrote a book together some years ago, published by Harvard University Press, which is what you see there. And that's how some of our ideas began. And at the same time, Russ was just completing a study with Larry on a group home setting study in which it was shown that people improved with cognition if they were in group home settings, if there were kind of social components as well, in addition to the cognitive components. So, the other important point I want to make is, given that this is a MapNet meeting with the majority of the audience being focused on early course psychosis, it's important to remind ourselves that schizophrenia is a lifelong illness that kind of begins almost at birth. And the characteristic psychosis symptoms begin in adolescence. But what persists all through the illness, during the prodromal psychotic and the stable longitudinal course of the illness, is cognitive impairment. It's present in the premorbid phase. It, it declines further in the prodromal phase and is fully evident by the first psychotic episode. As you see this slide, which is a summary of um, I lost my slide for a moment. 1 second. So, do you see it back now?
It's loading. Yep. Yes, it's back.
Yeah. So, what we see, now I'll put it on this slideshow board again. Okay. So, if you look at the effect sizes of cognitive impairment in this illness, premorbid phase of the illness, before any symptoms begin, there is about a half a standard deviation impairment in cognition already. During the prodromal phase, there is about a three-fourths standard deviation cognitive impairment. By the first episode, it's a full one standard deviation and a little bit worse in the more chronic patients. This was a series of meta-analyses that were pulled together in a paper that Larry led, um, many years ago. So, what are the cognitive deficits in this illness? There are broadly two categories. There are those that require what we call neurocognition, which can best be summarized in this acronym SMART, which stands for psychomotor speed, memory, attention, reasoning, and what we might call tact or social cognition. These cognitive impairments, just like the surgeon, when he goes to the operating table, he just doesn't remember why he came here. So that is neurocognition, plain and simple. And then there is the bottom right cartoon, the person not being able to understand from reading facial emotional expressions of the woman he is trying to date and goes and acts anyway. And there's this lack of social perception. So, social cognition is an important component of cognition that is impaired in this illness. Cognitive deficits in schizophrenia are pervasive. They are present across multiple domains, like the five domains above, as well as they're persistent between the prodromal psychosis and chronic phases of the illness. They're present early in the illness, and they may also progress early in the illness, and they predict functional disability. So, this is kind of a summary of what we know about neurocognition. And also, patients with the illness have a problem in thinking in a big picture kind of way, what you might call a gestalt thinking or strategic thinking. And why do individuals with schizophrenia have these kind of cognitive difficulties? That is because the brain problem in this illness is a problem of brain plasticity. When two neurons fire together, they wire together. That's a basic principle of neuroplasticity, which is impaired in this illness. And it's like a brain muscle that needs to be trained in order to make it function better. So that is the principle of use it or lose it, or and you sync it or you link it. There are many aphorisms that you can use for that. And in schizophrenia, there is a loss of synapses. There may be too much of pruning of synapses in this illness, and this loss of synapses might lead to reduced cortical thickness that might underlie this impaired neuroplasticity, which underlies cognitive impairment. And studies quite consistently have shown that training cognition using neurocognitive remediation works. And in this meta-analysis from Tilwikes, anything to the right of the red line is better than control interventions. And you can see that across a large number of studies, the cognitive remediation works better than controls in improving cognition. Over a couple of decades ago, my former mentor, the late Professor Gerard Hogarty, developed this approach called cognitive enhancement therapy, where he combined neurocognitive remediation with social cognitive remediation, um, conducted in individual therapy settings, in group sessions, as well as computer based exercises. Originally, it was developed as a 24 months intervention, and then it was published to be effective in an 18-month intervention, and then a 12-month intervention. This involves weekly exercises using computer based exercises, 1 to 1.5 hours per week, done in pairs. Two patients, along with a coach, sit together and do various exercises that involve attention, memory, executive function, and so on. And these are followed by weekly social cognitive group therapy, which address several aspects of what we call social cognition that include the ability to take the perspective of the other individual, understanding the social context appropriately, understanding other people's emotions, um, nonverbal communication, acting wisely in social situations, taking big picture of situations in day-to-day life, and so on. These are done in groups as well as through homework between groups, about 1.5 hours per week, about 45 sessions, a total of about 1 year. And we have done 3 independent controlled trials, one with chronic schizophrenia going back to 2004, and one in the early 2000s in first episode psychosis patients, and then a second first episode psychosis study as well, which was completed more recently. All of them have shown that cognitive enhancements therapy was superior to supportive therapy, and these benefits appeared to last even beyond the time that the treatment was run, suggesting durability. And we also showed in the first episode sample that in parallel to cognitive improvements, uh, the brain biology also appears to change. A number of brain regions involved in social cognition, such as the insula, the amygdala, the fusiform gyrus, the anterior cingulate, they all either did not decline in their gray matter volume or they actually got better during the intervention. So this is a slide to show that even at the end of the intervention, the benefits seem to have persisted. And the benefits seem to generalize to not only cognition, but also employability, social functioning, and activities of daily living, as well as negative symptoms, and to some extent, anxiety and depression. Positive symptoms did not change, but because most of these patients were already stabilized in their positive psychotic symptoms. So that brings me to social skills training. Um, Kim Muser, who is a leader in this intervention, is in the audience. He is our collaborator in this study, along with Sarah Pratt and Megan Santos. So this is another important evidence-based intervention in the management of schizophrenia patients. The variation of social skills training that we used in this study is called HOPES. It involves two key goals. One is rehabilitation using a skills training group and community living skills, social skills, and health related skills, and also healthcare management. Um, so there are manuals written for this. I won't go into too many of these details. It is manual driven for various domains of social skills and social functioning. Um, and so I'm sure if those of you who may have questions could ask Dr. Muser, who's in the audience, and he will be able to tell you more about social skills training. Again, control trials have shown that um, social skills training is also, like CET, quite effective in the overall um, management of schizophrenia and for similar durations, the trials have shown that the superiority compared to control interventions across a number of domains, including self-reported individual independent living skills. So, PCORI, which is a federal sponsoring agency, patient-centered outcomes research institute, um, offers support for studies that compare evidence-based interventions when there is when there is what you might call a decisional dilemma, when clinicians are faced with a goal of improving community functioning in someone with serious mental illness like schizophrenia, and there are two choices available of either social skills training or cognitive enhancement therapy. How do we go about deciding which patient should get what treatment and so on? So this is what motivated us to compare these two interventions, and we had a number of discussions. Um, Kristen Woodbury, who's in the audience, is the one who's very astutely suggested, why don't you compare CET and social skills training some years ago? So we designed the study uh, to compare these two evidence-based interventions. So our goals were, are they, how do they stack up against each other when you do a comparison of these two interventions? And um, is it who benefits more from cognitive enhancement therapy and who might benefit more from social skills interventions? And we want to look at the effect of baseline cognitive function and age as potential moderators of outcomes. So this slide kind of summarizes our goals, what are baseline moderators that we examined, and the key elements of intervention. CET involving manual-based computer sessions, with a training and trainer and partner, and also individual and group settings. 6 to 8 participants, focusing on neurocognition and social cognition and social skills training. Also had weekly skills training sessions and practice sessions and socialization and community trips. And this is what we were able to accomplish during the study. This is our consort diagram. There were initially 31 sites, and because of the various challenges related to the pandemic and the post-pandemic, we lost a number of sites and had to replace. And finally, we had 13 and 7. And here are the numbers of how many we enrolled and how many we had the baseline and follow-up data and so on. These were our assessments, both symptomatology, cognition, social skills, community functioning, as well as quality of life. These were all the assessments that we did. Diagnosis was determined by many interviews, and these ratings were done at baseline 6 months, 12 months, 18 months, and 24 months. And these were our process measures. We also examined treatment fidelity, treatment engagement, clinician experience, patient experience, treatment satisfaction, and service utilization. So, is this where I switch to? Yeah, this is where maybe Russ, you could take from this point because these are results. So I'll stop here and Dr. Schutt will open his presentation and will present the rest of the results.
Thank you, Dr. Keshavan. Um, let's see, can we confirm that you can see my slides?
No, we are not seeing it yet.
Not showing up yet. Yep.
Okay.
Yeah, now we do.
Yeah. So, okay, is that good now?
Yeah.
Yes, looks great.
Okay, so we, as Dr. Keshavan said, had to confront the pandemic at the outset of the study, which was launched in January of 2020. So, of course, we didn't even get as far as creating any groups by March. After the end of the year, PCORI agreed to sponsor a pilot study of remote procedures. And just to share some of what we learned from that, the site PIs that we were working with at the time in a survey, it indicated that client reactions to the idea of remote delivery of services was generally positive, but with more acceptance of that for individual therapy sessions as opposed to group therapy sessions. Now, fortunately, the pandemic had remitted subsequently in time to allow us to launch the project with group sessions in person. And except for one site, all the group sessions were delivered in person. We did, not being sure at that during that pilot project, whether the pandemic would continue or recur, we developed rules for that would justify switching to remote procedures. And if the pandemic did recur, that didn't happen. So again, all of our sessions, except at one site, were delivered. The group sessions were delivered in person, but it's perhaps important to know that we allowed remote delivery of individual sessions, whether cognitive remediation in CET or community support sessions in HOPES. And that did occur to varying degrees in both treatments. So as Kesh has already indicated in relation to the research questions, we were examining the difference between CET and social skills training, particularly the HOPES version developed by Drs. Muser and Pratt. And our hypothesis was that there would be more improvement with CET, again, based on meta-analyses of effect sizes in prior research. We also predicted more gains with CET if individuals were younger. Again, the issue of brain plasticity that Kesh talked about, and if individuals began with lower baseline cognition, in other words, needing more of a focus on cognitive remediation to improve. So this is the first slide to provide findings from the project. These are findings from baseline 6 months, 12 months, 18 months. Now, remember, the treatments were 1 year in length. So 12 months is the end of treatment, 8 months, 18 months is follow-up after 6 months. And it's also important to note that these are intention to treat analyses, so that the lines here follow everyone who we were able to collect outcome assessments from, whether they remained in the treatment or not. And as you can see here, in terms of different measures of cognitive functioning, there was improvement in both groups. There was, and not a differential between the two treatments, significant gains in both. In terms of social functioning, we also saw improvement in both groups, although in this case, there were more gains on 2 dimensions of social functioning with CET compared to HOPES. That's what you see on the left here, where, as the footnote indicates, lower is better. So on the left, in terms of global role performance, more improvement in CET than HOPES, and the same in terms of the personal well-being dimension of the SAS measure of social functioning. On the right, the social skills performance, you see improved also for both groups over the course of the study. And their higher scores do mean better functioning. And then this looks at the one dimension of the PANS scale, positive and negative symptom scale, which we the hypothesized effect in our research protocol was on negative symptoms. In other words, we hypothesized that negative symptoms would improve and more in CET, and that is exactly what we found here. Both are, again, an improvement in both groups, but more improvement in the CET over time. In terms of quality of life, this just presents the total scores on quality of life. Those scores, as you may know, can be broken up into many different components. But for the overall score, again, we see gains with both treatments, no significant interaction to suggest one was preferable to the other. So we, again, also hypothesized interactions, moderation effects of age and of baseline cognition. And I've highlighted here in red these significant findings, which were broadly in line with our hypotheses, but didn't occur with each measure. So in terms of social skills, there was an improvement, a greater improvement with CET for younger persons. This is just basically a median split at 35, and also more impact of CET for those with lower baseline cognition. And in terms of quality of life, same interaction in terms of greater impact of CET for clients who are younger. In this case, no effect of baseline cognition with a composite measure of cognition, no moderation effect of either age or baseline cognition. Same in terms of the social skills performance, no moderation effect. But in terms of the Mesquite, this is the measure of social cognition. We see more improvement for those who are younger as hypothesized. Again, no moderation effect of baseline cognition. So we also, with this slide, we'd like to shift to drawing your attention to the implementation experience, both because we analyzed it systematically, but more because we'd like to encourage all of you involved in treatment delivery, whether as administrators or clinicians or clients who are seeking this kind of experience, to encourage thinking about, well, could we implement this at our site, or what would it take? So first of all, with our site PIs, they reported in our post-project assessment high levels of participation of participants in the groups, as well as in the individual components, weekly in CET, monthly in HOPES, although not as high consistently as with the group participation. But these are great, I think, indicators of how people really cared about participating in the groups. Again, the numbers here are sites, not participants. And again, overwhelmingly positive ratings of the clinician experience. from the perspective of the site PIs. I'll get to clinicians in a minute, and a belief that all the participants benefited somewhat, and almost all of them said a great deal from the experience. The most challenging part of the project for the site PIs and the clinicians was recruitment. So you can see here, most sites found it difficult, a little bit more difficulty reported with recruitment for hopes, I think related to just particulars about a couple of sites and distances involved and so on. But that means clearly recruitment has to be very carefully planned and done systematically and with some attention to resources. This slide is based on records based on the sites as the units here, the blue and the red bars, about group attendance and about group attendance. And the blue bar is in person and remote. The red bars include, and as you know, there was very little remote attendance as far as group goes. The red bars include makeup sessions. And you can see here that the blue bars show an advantage for CET in terms of attendance, but when makeup sessions are included, the two treatments were about equivalent in terms of the attendance in the groups. And here we're again showing data by site about project implementation. This looks at attendance in the weekly individual sessions in CET compared to attendance at the monthly individual sessions, normally involving a community support person as well as a clinician in hopes. And you can see there's quite a bit more variability between sites in terms of the monthly individual sessions. So again, just something that Drs. Muser and Pratt will be able to comment about, but showing the importance of really planning and providing resources to help those meetings to happen. These two charts are a bit data heavy, but didn't want to spend too much time with this. These are clinician feedback ratings about their experiences with the two treatments. In general, similar for CET and hopes, but differed in terms of the treatment components. So you can see that in terms of client experience, the clinician ratings are overwhelmingly positive. You see the legend down at the bottom, mostly positive. Positive are the long bars here for both treatments in terms of clinician feedback about the client experience. Somewhat more positive ratings about the individual sessions in CT, but remember that we're kind of comparing apples and oranges here because CET sessions are these regular weekly sessions, the individual sessions, that is, whereas monthly in hopes. And so, of course, that's the computer sessions only occur. in the CET. If we look at the clinician ratings of the group experience, you see mixed ratings, frankly, in both treatments. So we provided our treatment experts, provided weekly supervision for the groups, and a lot of support to the clinicians. But these may have been more challenging than the treatments than what the clinicians were used to. Again, both manualized, but there's an awful lot to deal with. You see, there were generally challenges reported in launching the treatment and recruitment for it. As you've already seen in terms of the ratings of the site PIs. So these are clinicians backing up that picture reports the ratings of the training experience are overwhelmingly positive for both treatments. So we also conducted qualitative interviews, basically with two randomly selected participants, 2 months after the treatment began for them, after the group sessions began, and about 2 months to depending on scheduling issues for the assessments, at a month before the treatment ended, or sometimes right up to the end, or shortly thereafter. And the pictures here are of our two qualitative interviewers in the project, Tracy Reed on the left and Laura Golden on the right, who both did fantastic work in getting these interviews scheduled and done. And the transcriptions are just real testaments to their skills, as well as to the value that the participants reported in their own words about the experience. And Laura and Tracy have summarized the change in terms of one dimension here that they coded that they found was really important to clients and where they saw really the effect of treatment. So just looking at social goals. So at 2 months, the green heading here, they talked about, distancing from old friends, primarily social relations with immediate family, and asked about their prior lives. They noted few goals, having few goals related to social engagement. But as it is summarized at the bottom here, social goals and engaged social engagement increased with both interventions. You see, at the 11-month point, that is the second qualitative interview, and these were, again, with two randomly selected clients from each group. They were not, the random selections were independent, so the same person could have been interviewed both times. Generally, they were different people interviewed at the two time points. You see, they saw increased social engagement through treatment, a sense of belonging that led to friendships, some even and friendships with the cognitive remediation partners. The cognitive remediation sessions outside of the group sessions in CET are supposed to be delivered with a partner. that wasn't always the case, but in fact, it was a very meaningful connection for many people. Sense of belonging, again, led to friendships with other participants in the groups and a feeling of, a nice social experience. Looking ahead, um, participants talked about reconnecting with old friends, wanting to make new friends, and an interest in dating, romantic connections. In fact, there was one marriage that resulted from this process in one of our groups. And again, other partnerships like that, but mostly forward looking. These are some quotes, just giving you, again, the flavor of what clients themselves said about the experience. I'm actually surprised at how well we're getting along. I like how it's structured, so that way everybody gets a chance to speak up. I thought this is someone who was in the group, the site that included, that maintained telehealth, that it would be difficult, but it's fairly easy because all of you guys send me emails with the meeting. So I just click it, it works. Lower right here, it's just nice to see that there's people who actually feel the same exact way that I do with similar concerns, a real sense of peer engagement and support. The Laura and Tracy, went through and coded these comments. The portion of the interview talking about relations with what they thought of their group mates, and you can see just overwhelmingly positive for both treatments. And even in this case, a bit of advantage for the hopes groups. And distinguishing the two treatments with the qualitative data. Here are one question was what participants felt, what you feel you got out of the experience. Or so here for CET, again, these are the 11-month interviews. I'd say it's excellent. I'm overwhelmed with the fact that it actually helped me in all areas, like confidence and being more social. Another one says I've definitely been more open, less shut off, increase in confidence. Another changed a lot as a result of being in the study, in part just the responsibility of having to attend and so on. And mentioning that individual sessions are therapeutic, and talking their way through situations, and listening to others' points of view. Here are some quotes from HOPE's participants. Just like having a group of people to talk to makes me feel like a little less lonely, a little more sense of belonging, more confident when I go to interviews, and also, comparing to other people and wanting to do things differently. This is talk about other people that they met in the group. Another reporting more confidence, have the tools and gone through them, and maybe like everybody else, but now they recognize strengths and weaknesses in terms of communication. We're obviously thinking more about that. Somebody says more likely to socialize, maybe a bit more outgoing, going to new places because of social skills training. And again, more goals to achieve bigger goals. So in both treatments, you see gains that were really meaningful to the participants themselves, described in their own words. To wrap up, there are certainly some limitations to the study. And again, workforce challenges, had a lot of hoops to jump through as a result of the pandemic and the resource constraints that it created for sites. In fact, multiple sites had launched challenges after the pandemic hit, even when we got around to recruiting sites for the full project. Again, we had to replace many sites that after the pandemic were just too stretched for resources to continue. But we did, and in fact, ended up with more sites out of New England than our original site sample, which I think gives us more confidence in the generalizability of our results. I've talked already about the recruitment and challenges with clients, and retention was an issue, not so much in the groups, but certainly in terms of continuing the assessments and maintaining contact after the groups finished. And of course, the total N that we had proposed and intended in our original proposal to PCORI was about double the one that we agreed to after the pandemic in a revised and more compressed research plan. So of course, that loses statistical power. If you're enthused, I hope, at this point about project success and want to learn more about it, this slide links you to our project website, which has a lot of information about the project, to a protocol article that we published about the project design with a lot of details, although that is based on the original design before the pandemic. And then this is a link to the official description of the site at PCORI's website. The RAISE program is a coordinated specialty care program that Dr. Keshavan will say more about at the end, but that is picking up from what we learned on building on the insight that these treatments are very important to provide early in the development of psychosis, where they can short circuit the process to some extent. So in terms of a summary and next steps, as you could see, implementation was successful, but I've talked about the barriers that we faced. It shows, our experience shows that this kind of year-long group treatment is feasible, both in terms of site PIs and clinicians. That in other words, in community settings, not just in research-connected facilities. The qualitative interviews show very positive client experience in both treatments, and our quantitative data show longitudinal improvements with both interventions on multiple dimensions, CET being more powerful with respect to community functioning. And we also identified moderation effects, particularly of age, that made generally CET more valuable and supports the notion of using it early rather than after a diagnosis of chronic illness. So we're focused on ways to sustain implementation in community settings. Um, and uh, just disclosures here. Um, Let me conclude by acknowledging that this was, in fact, a group effort, a team effort, a multiple group effort. And we are so grateful to and appreciative of all the fantastic people that we worked with. Um, our co-investigator team is indicated on the right here, and just terrific collaborators that we met with every week, and uh, including Kim Muser to my left in the screen, Luis Sandoval, Sarah Pratt, Sean Eek, Megan Santos, Raquel Mechlin Gately, and Hai Ji, who is our biostatistician at Dartmouth. And boy, have we been working closely together very recently up to this morning as we've gone through a very intensive analysis of our data, which Dr. Ji was really needed for. And on the left are project staff. I mentioned some of them. We are grateful to all of them. The lower right, our site PI group, really terrific collaborators. And Kristen Woodbury, by the way, I've got my pointer on right now, who Kesh mentioned as having initiated the idea and moved some time ago from her work at the Massachusetts Mental Health Center as a clinician to the main health enterprise. Our stakeholder committee was just great in giving us advice and feedback regularly. John Delman on the left here, Dr. Delman, was really part of the co-investigator group, was in our meetings every week throughout the project, and contributed enormous insights. And the whole stakeholder committee is composed of just really smart, insightful, experienced people who improved the project a lot. So thanks again to everyone. And I think Dr. Keshavan will have a bit more to say about the RAISE project and other things.
Yeah, thank you, Russ. The only thing that I would add to your summary is that the moderator analysis that you showed was quite interesting for us. The fact that younger people seem to have benefited more, and those with cognitive impairments appear to have benefited more. Both of them point to the importance of introducing these interventions early in the psychotic illness. So I had that one slide there of coordinated specialty care, the multiple elements that make up what we call coordinated specialty care, or CSC, which really is at the heart of the MapNet service. Now, so far, generally, what constitutes coordinated specialty care has been somewhat inconsistent across multiple settings and interventions, and so far does not consistently include some of what we might call disease modifying interventions, such as cognitive remediation and social skills training. And they really should become part of our regular standard um, treatment care plan within the first few years of the illness. So that's the one main point I would like to make. Thank you. We're open for questions or any thoughts from the audience and from other collaborators who are on this call.
Good, thank you both. And I'll just say I'll respond to a couple folks in the chat that yes, we'll make all of the resources here available because I think there are some really great links and things in there that folks can use later. But feel free to put in the chat or unmute. One general question that I'm thinking of as both of you are speaking to each of these, I'm thinking very much about the kind of long gap between, when we know something is useful and when it's been shown to be really helpful, and then when it actually can get implemented kind of systematically for folks in the real world. So, what are things either for cognition or social skills training that you think folks can be doing kind of right now or in the near future to start addressing some of those, even if it's not like this full intervention?
Yeah, so that's an important question, Kelsey. So there is this what is called implementation gap. From the time a given intervention is shown to be effective in a ivory tower academic setting to the point where it becomes implemented in a community site, there is both a delay and a loss. Many of these interventions just don't get implemented, and when they do, there is a delay. The usual length of time that is often projected in psychopharmacology is 17 years on an average, from a drug development and showing efficacy in a clinical trial to its implementation in a community setting and so on. In psychosocial treatments, it might be even longer. And this is where the whole field of implementation science is such an important thing. And and this is where also it's important to use the principles of what we call learning health systems, and that is um, implement something and then you know do research in the practice itself, in the sense if we are implementing, say, CET or social skills training, get feedback from the clinicians and the participants and other stakeholders early itself as to what are the potential barriers and what might be the potential facilitators, and then revise the intervention and put it back into practice. Now, one of the barriers that we saw, which Dr. Shute showed, is recruitment was a big issue. It seemed to me that one of the challenges of recruitment here was simply the whole process that characterizes research, which is getting an IRB approved and getting consent from people for a consent form that has 15 pages in it. So that itself is an implementation barrier, but thankfully that barrier doesn't exist when you do a complementary, say when you do a clinical implementation, where you have the freedom to revise and adapt and make it more flexible, not being dependent on rigid criteria of research and so on. So that could be a benefit going forward. So we are hoping that across multiple sites which have expressed interest in implementing a continuation of these interventions in their clinics, we would very much be willing to be involved in providing any kind of consultation going forward. So, Russ, you may have more to say about that as well.
Thank you. Yes, I do think that one point that we'd like to emphasize about our findings in the process of providing these treatments is that they focus on aspects of functioning that are not improved by available psychotropic medication. The cognitive deficits and the particularly the social skills deficits that were represented in Dr. Keshavan's early diagram are persistent, as he said, and create the greatest barriers to community functioning. And so part of the issue is, showing motivation is not just an issue with clients, it's an issue with health systems and clinicians, showing that spending the time to provide these group oriented treatments instead of what may be now just a lunch opportunity or some casual interaction, providing systematic treatment like this in a group form is really beneficial. And don't we want to help people get to a point where they are engaged in the community, have more social connection, and thus are able to function in a much better framework in the community.
And I'll read out to what Kim put in the chat here, saying in the Navigate CSC intervention within the IRT individual resiliency training component, there are some optional modules to help clients improve their social relationships. However, this is social skills training done on an individual basis, not a group basis, as was studied in Project Success. I can add to that, a lot of our teams do have general group programs or group like more social groups that they're offering. So maybe there are ways to kind of pull in those existing IRT modules to those settings, kind of taking advantage, Kesh, like you're saying, of what is already being done, rather than trying to bring something new in.
Yeah, and I would add to that what I think is an important point, and something that I learned in the earlier study that Dr. Keshvan referred to, involving a comparison of living in group versus independent housing. And that project was funded by NIMH, National Institute of Mental Health, and HUD in a collaborative relationship. Would that were possible again, in 1990. And we followed, people were in these homes that they were randomized to get from homeless shelters, okay, but with diagnoses of serious mental illness. And what but the group home living, as Dr. Keshavan said, was better in the long term for people, but the cognitive gains were really just around one dimension, executive functioning. And in general, we didn't see the kind of multi-dimensional improvements that we have in our project. And I wrote a book about that, if you're interested, anyone, also with Harvard University Press. The I think the reason for that is that it was group home living without the kind of structure and treatment orientation that Project Success provided. There were not these weekly, systematically designed and delivered group sessions, and all these other elements. And so just being in a setting with other people versus living alone was not enough.
And that is maybe a great connection to Danielle, your question in the chat. I see you're on video. Do you want to ask that out loud? I can also read it out.
Yeah, sure. I'll go ahead. First of all, thank you so much for this fantastic presentation. I'm a medical student actually at UMass Chan applying to psychiatry this year. So very excited to be here. I work with Dr. Saldua Fan and UMass Mind, which, as some of you guys know, provides community intervention for people with SMI. And we particularly work with people in group homes. So my question was regarding retention. I have led some similar projects in the past, and that was my main challenge. There would be, several participants who sign up in the beginning, but as we go forth with sessions, we would lose people. and attendance would be poor. So I know you briefly addressed this in your slide on makeup sessions, but I was just wondering if you could share any advice or strategies for improving engagement and retention as I hopefully continue to implement similar
Yeah,
community
so that's a
projects
great
with this
question,
population.
Daniel. So a couple of thoughts. One is what we have found is that one of the common reasons people drop out early on is simply because it's too intensive and too long. 1 year is a long period of time, and Russ put on in the chat the note that Sean Eek, who has been my collaborator for many years in CET, has developed a 6-month version, which is of CET, which is currently being evaluated for potential funding, and some preliminary experience exists. So that's one way, maybe to shorten the intervention, whether we could get similar benefits, followed by booster sessions, perhaps. So that could be applied for both CET and social skills training approaches. The second thing is um, some of these interventions, these days people don't want to come into clinics. Virtual mode of delivery has become more the mainstream than in person. And whether we could adapt these interventions to become even more friendly and technologically easier to deliver as remote interventions. And thirdly, whether there are a lot more that could be done in terms of developing manuals for patients to kind of do homework and help themselves with these principles. Um, in addition to some uh, elements of the overall intervention that they get to help with a clinician and a coach. So the more we kind of develop them as self-help kind of strategies as well, that would be another way to increase retention, if you will.
Sounds good. Thank you so much. Hopefully
Yeah.
I can go back and speak with Dr. Fan after this and see if we can, go back to being a remote site for this
Yeah.
project.
Yeah, the project research itself has ended, but we encourage the clinics to implement them, and now they are billable. And we have talked several times in this MapNet community meetings about a billing code that could be like a comprehensive bundled billing, which could include interventions like social skills training and cognitive remediation. But of course, there is some level of expertise that is needed for these interventions. And there are manuals available. We can make them available. We could also provide consultation going forward for local implementation.
And that actually ties to another question in the chat. So, what kind of training and preparation would clinicians need to be able to implement the group CET module?
Yeah, I can say that a little bit for CET, and maybe Dr. Muser can comment on social skills training as well. So we were able to train clinicians in 4 half days of virtual training, and we have videotaped sessions for those. So that's kind of a module that we have developed, and Sean Eek has a website that can help as well with this.
I would also add that it's important to understand that for clinicians who are new to these treatments, it's also expected that there will be weekly supervision sessions by an expert. Some of whom are on this call, but that involved in our case, and is a normal practice, a review of a recording of a session and rating it often against a fidelity instrument. And, the idea is that after this kind of year of combined supervision and training on a weekly basis, that the clinicians will be all set, for the next time around. So it is an investment. And again, our most important message, I think, is that it is worth it.
And catch, like you said, potentially billable as well, which I know is another huge,
Yeah. Yeah.
yeah, piece of
Yeah,
that.
which did work out at our sites. There were
Mm.
challenges with some.
Great. Going back in the chat a little bit, we had a question, do either social skills training or cognitive remediation reduce relapses? So was hospitalization or those sorts of measures something you guys were measuring?
Yeah, so we recruited people mostly who were stable and
Mhm.
were not particularly experiencing psychotic symptoms. And we did not examine relapse rates as an outcome measure. So, but we did look at psychosis itself. Psychosis ratings did not seem to differ. These interventions are not designed to prevent relapse. That's not there. Even though social skills training, which has an illness management component, may have a positive effect on preventing relapse by, um, illness management. So, but we did not formally examine that in this study.
Although informally, I would add that on multiple outcome measures assessing functioning and feelings, there was not uh, a relapse trend, a lessening trend between 12 months when the treatment ended and 6 months later at 18 months when people were assessed again. Many of them were also assessed at 24 months, but there wasn't enough time to do that with everyone.
Kim, did you want to add something? Yeah.
Yeah, we did, Matt Kurtz and I, a number of years back, did a meta-analysis on the effects of social skills training on community functioning, social skills, symptoms, and we did look at relapse and rehospitalization. And in the meta-analysis, we did see a small effect on preventing relapse and rehospitalization. And that makes sense if you look at the stress vulnerability model. One of the factors that moderates or buffers the effects of stress is social support. So any intervention that is effective at improving the quality of social relationships and presumably, therefore, the quality of social support would be expected to have a modest effect on reducing relapses.
Yeah, very helpful. Thank you. I also want to point out, Kim said some other great comments in the chat in response to some questions. Really great to have multiple experts from the study on this on the call here. Yeah, any other questions or thoughts that people want to bring up? Oh, and one question. So John says, I may have missed this, but are there plans for extended follow-up? So yeah, what are the next steps for the project?
Yeah, I have to say that the project is concluded. The funding has all been used. And in fact, as things happen, we ended up having Kesh had to contribute money from his endowed chair to keep us fully funded through the end of the project, and the our department, the psychiatry department at BIDMC, was able to help some. So I'm afraid that there are no plans for extended follow-up, at least formally at this point. I will say I managed to get a small grant years ago in that housing study, long after it was over, to follow up people and interview them about 20 years out. So maybe there's
Yeah, no,
hope.
what I would like to add is that Sean Eek has developed this 6-month community-wide feasibility implementation study, which is kind of under review in NIH, we are a part of that as well. So we'll have to see. That may be one logical next step for this. And also, we're always trying new grants to ask important questions. And this is an important question. What happens to people who received these interventions, and how did they do 5 years down the road and 10 years down the road and so on? We did a similar study in Pittsburgh, and it's not published yet, but the 10-year data showed that the benefits of CET still persisted to some extent. So, yeah, these are important questions. So we'll keep that in mind.
Great, and a great follow-up from Margaret. So another question is how to get this good news report in front of policymakers and funders. So how can we share this message?
That's a great
Yeah,
point. It is
yeah.
up to us to develop summary papers for different audiences, including the scientific audience through peer-reviewed journals, but also white papers to policymakers and funding agencies. So that's on our list of things to do.
Yeah. I might add that Picori, our funder for the study, by far the primary funder and the motivation for it, actually requires a very extensive report on projects at the end. We are just finishing that up, our so-called DFRR, Draft Final Research Report. It's due next month. And at the moment, we're really focused on that, which is very comprehensive and has involved many contributions from our collaborators like Kim and Sarah and IEG at Dartmouth again. But that will both be a document that others can use to learn about the details, but will also, for us, provide a foundation for going off in a lot of different directions with articles about this. Our program managers at Picori, by the way, tell us that these DFRRs, which are big formal documents, are posted by them on a public website, are examined by others, fairly broad attention to them in the provider community.
I wonder if I might ask a question. I know your work, thanks very much, is really interesting. I think it's great to see the positive results of this. The work was based in groups, and I'm wondering if the same gains can be, or similar gains can be expected in a one-to-one basis, potentially even by having parents talk to their kids, and how, if that's a possibility, how is the best way to do that?
That's a great idea. So that kind of a family involvement and family serving as potential coaches for social skills and cognitive training and so on is a great um, idea to be tested in the younger population, because the older and the more chronically ill individuals have less such family availability. So some years ago, if I remember right, Michelle Friedman Yakubian did a study to that effect. She developed a model of intervention where the family members themselves serve as coaches and are family assisted. It was called a FACET study, family assisted cognitive training. So I don't know whether that has been followed up further. So that's a great idea for the future.
Thank you for that. And I also wanted to respond to a question from Margaret Geyer in the chat. Ms. Geyer is an administrator at the Massachusetts Department of Mental Health and was also in that role a member of our stakeholder committee. And she asked about publicizing this more broadly to potential funders, state administrators, and so on. And frankly, after that housing study I mentioned, the Department of Mental Health sponsored a public address in the auditorium at Solomon Carter Fuller about the project that was, my recollection from the stage, was just packed. And I think that those of you, certainly, thank you, Margaret, who have connections to state mental health agencies, we would love the opportunity to present these findings in that way. And thank you for all your support during the project.
Yeah, thanks, Kim, for putting that paper on the chat. Yeah, that's wonderful. Thanks, Margaret.
So we have time for maybe one more question if anyone has a last thought, something we can look at.
Well, I want to say that we are still analyzing and understanding this data, and we'll certainly be back to this group to share more as we learn.
I could make just one very brief point, which is to say that, as I think many people know, social skills training is an approach to teaching interpersonal skills that can be implemented in long-term programs such as the HOPES program, but also shorter-term programs, say 3 months, 6 months, depending on the curriculum that you want to teach. You could have an interpersonal dating skills group or a group for improving work-related skills and the like. And so there's a great deal of flexibility built into the model itself. There's one a single social skills training program that's the right program for everybody. And it's quite possible that in the present study, the HOPES program didn't have quite enough curriculum oriented towards the needs of younger individuals. So there's a lot of individual tailoring that can be done by clinicians who are interested in implementing that.
Thank you, Kim. That's very important. Maybe HOPES, younger version of HOPES is one of the next goals.
Well, great. Thank you, everybody, for a great discussion, and we'll look forward to hearing more about this as things move forward. But really appreciate you talking about it today.
Thank you.
Yeah. Happy
Thank
Friday,
you.
everyone.
Hello? I didn't. Oh.